Hello, everybody. Our recording is in progress. Welcome to the webinar on home visiting, cross-system strategies for home visiting and child welfare. So I would like for you all to put your name and where you're from in the chat. I see lots of people are coming in the room right now. We're going to give it a sec. We usually have people from all over the country, so it's always really good to see who's here. And often what happens is that people will see friends in the chat, and then they will start having a chat with their friends. So it's always good to let folks know that you're here. We appreciate you being here, and we're going to get started in just a second. So the first slide that you're seeing is inviting people to join our exchange, and going to have a little another slide at the end that will tell you how to do it. But there's on the right-hand side, you'll see some of the benefits of joining our exchange. It's really an online community for exchanging information and questions and resources and all those kinds of things. Okay, all righty. So here we are. This is webinar number 4 of our series on moving away from family separation, cross-system strategies to support young children and families at risk of child welfare involvement. Today, we are doing home visiting and child welfare from policy to nuts and bolts. I am your moderator, Cynthia Tate, with the BUILD Initiative. We are going to have interpretation and translation services by Valentina. So Valentina, you want to tell everybody how this works?
Absolutely. Thank you so much, Cynthia. Hi, everyone. Good afternoon. My name is Valentina, and I'm here on behalf of Community Language Cooperative. I am here to provide and guarantee your commitment to language justice. Language justice is a type of simultaneous interpretation that seeks to create spaces in which no one language is dominant, spaces in which everyone can participate in the language of their heart. So to achieve this objective, we will be using Zoom's interpretation feature. What you will see in a couple of minutes is that a new little button that looks like a globe will appear on the bottom bar of your screen, on that same bar where you currently have the buttons for the microphone, for the video, for the chat, etc. It'll be towards your right hand. Once you see this new little button come up, go ahead and click on it and select either English or Spanish as both the language that you will be listening into and speaking into. If you are joining the meeting on a phone or on a tablet, you will find the same options for interpretation by clicking on the button with the 3 little dots on the lower right-hand corner of your screen. This button reads more. Hola a todos, a todas y a todos. Buenas tardes. Mi nombre es Valentina y estoy aquí por parte de Community Language Cooperative y estoy aquí para ofrecerles y garantizar su compromiso con la justicia del lenguaje. La justicia del lenguaje es un tipo de interpretación simultánea que busca crear espacios en los que no domine ningún idioma, espacios en los que todos puedan participar en el idioma de su corazón. Para lograr este objetivo vamos a utilizar la función de interpretación de Zoom. Lo que verán en un par de minutitos es que aparecerá un nuevo botón que parece un globo terráqueo en la barra inferior de su pantalla. En esa misma barra donde ahorita tienen los botones para el micrófono, para el video, para el chat, etc. Va a estar hacia su mano derecha. Una vez que vean este botoncito aparecer, hagan clic en él y seleccionen inglés o español como el idioma en el que desean escuchar y participar. Si usted está en esta sesión por medio de una tableta o de un teléfono, encontrará las mismas opciones para la interpretación haciendo clic en el botón que tiene 3 puntitos en la esquina inferior derecha de su pantalla. Ese botoncito dirá More o Más. A quick reminder for those of you that do prefer to use English during this meeting, Spanish is 20 to 25% longer than English, so please be aware of your speed. Everyone must select a language channel, regardless of whether you are English, monolingual English speakers, or monolingual Spanish speakers. Only those of you that are fully bilingual can choose to ignore the service. If you have any questions or any issues whatsoever with this technology, please let the whole group know by means of the chat box so that we can work together to address them. Un breve recordatorio es que la interpretación es simultánea, entonces cuando participe mantenga un ritmo de conversación. Si tiene alguna pregunta o algún problema con esta tecnología, por favor comuníqueselo al grupo completo a través del chat para que lo podamos resolver en conjunto. Muchas gracias por tenerme por acá. Vamos a activar los canales de interpretación ahora. Thank you so much for having me here. We can go ahead and start the interpretation channels now.
Okay, thank you. Thank you, Valentina. All right, so the objectives of our webinar series, this is for the whole series of which, as I said, this is number 4, are to raise awareness about young children and their families involved with or at risk for involvement in the child welfare system, to educate participants about the racial disparities in family separation from child welfare involvement, to promote opportunities and upstream strategies for prevention, and to provide examples of cross-systems collaboration on behalf of young children. So for this particular, we can move this, oh, there we go. For this particular webinar, we are going to hear the origin story from Illinois about how home visiting policy started, was enacted in the Child Welfare Department. We're going to get a national perspective on the challenges to implementing home visiting in child welfare systems and some recommendations to meet those challenges. We're going to learn how Indiana expanded and funded its home visiting system under the Family First Prevention Services Act, and to receive benefits here from a perspective on the ground, from the nuts and bolts of engaging and serving families through home visiting. And here are our distinguished, knowledgeable presenters who I am so happy to have here today with us and to have them share their knowledge with you. We have Kat McDonald. Kat is the founder and president of Linchpin Strategies, whose firm, the Linchpin Strategies, did the report that you will be talking about. And we have David Reed. David is the Director of Child Welfare Services at the Indiana Department of Child Services. Hi, David. We have Kimberly Mann. Dr. Mann is the chairperson of the Department of Social Work at Chicago State University. Hello, Dr. Mann. And we have Pfeffer Eisen, who directs the Erickson Institute DCFS Early Childhood Project. Hi, Pfeffer. Okay. So that's who our presenters are. Who are you? The people who are on this call or have registered for this webinar are really across the board. We have preschool development grant directors, lead parent educators, we have staff analysts, we have administrative assistants, we've got supervisors, breastfeeding coordinator, program directors. We have a lot of different folks. So we have a MCH nurse consultant. So we just really appreciate all of you joining us today, and we hope that you are both informed and inspired. There are over 700 registrants for this particular webinar from 46 states and DC and the Virgin Islands. You are from a wide variety of different kinds of organizations, from state departments of children, youth, and families, to parent networks, foundations, county and state government, universities, and other research institutes. So you're from a wide variety of organizations. And that's just great because we have a variety of organizations represented by our panel. So we did ask what people wanted to learn about in addition to the topic for today. And as you can see, there are an awful lot of things that people want to know about. And so we're really going to do our best as an organization. BUILD offers a number of different webinars on a number of different topics. We are going to do our best to be responsive and to offer for you what it is that you say you want to learn about. Now, how do you participate in this? I just love that face. Look at that baby. First of all, introduce yourself in the chat, as I said before. Put your questions for the panelists either in the chat or the Q&A. There will be a time during this webinar where we will pull those questions and we will have a discussion and response to your questions. And at the end, we have a survey. And that's really to let us know how we did. At BUILD, we really do seriously care about how you experienced our webinars. We want to know if they met your expectations. We want to know if they gave you actionable information. We want to know a number of things. So the survey is going to pop up at the end. It doesn't take that long, but it's really important to us. And so we appreciate your doing that. All right, we're going to start with a little video just so that we are always grounded in the reason why we're here.
There's just a lot of stress in my house with a baby and just kind of navigating through all that and what I have to do next.
We all know that parenting is a very, very difficult job. With Healthy Families America, we just come in the home to give support, build a relationship, and to alleviate some of the stress that parents deal with in order for them to create a more fulfilling, closer bond with their child.
She just reminds me, like, yes, you've gone through a lot, but we're getting through it, and we're getting through it not only together, but like whatever I need help with, like she's just there. We talk about what's going on in life, what's new, milestones as far as where the journey should be.
So let's look at the new book. It says my nose, your nose. Where's your nose?
In the Growing Great Kids curriculum, we do a lot of activities that involve homemade toys, and they're just made with things that you can find around your house. It really promotes parent-child interaction. It's just something fun where parents can build with their child while they're kind of working on brain builders such as understanding space.
I think consistency is important, especially for me because I haven't had that. I don't remember that growing up. There's a lot of chaos. She shows up, she's always there, and I can really rely on her. There's peace in that. It's comfortable.
So thank you to Nebraska's MCV program. Home visitors are important to the families that they work with. So now we're going to turn to Kat. Kat McDonald, you're on.
Thank you, Cynthia. And doesn't that just warm your heart? It makes me smile and tear up a little bit every time I see that video. Thank you so much for including us. I'm so excited to join you today. My name is Katrina McDonald, and I am the Executive Director of the Association of State and Tribal Home Visiting Initiatives. What a mouthful. We are also known as ASHVI, and we are the professional association of the state, tribal, and territorial administrators who oversee home visiting programs, primarily evidence-based home visiting programs funded through federal funds, but many of our members oversee home visiting programs funded through other sources as well. So if we could go to the next slide, just to give you a little bit of context for the work that we did. When the Family First Preventive Services Act came out, our association was very interested in working with our child welfare partners in state and tribal and territorial governments to try to figure out how those funds could be used to expand home visiting services to families who are either engaged in the Child Protective Services system or perhaps were at risk for engagement, but hadn't actually been involved with CPS yet. And so we hosted a meeting between home visiting officials and our child welfare counterparts. We had about 80 people in that conversation. For that discussion, it was entirely state officials who joined. We did not actually have any tribal or territorial officials who joined us. And about 40% of the folks in this small group discussion were from child welfare, and about 60% were from home visiting. As we talked, a number of barriers that have been widely talked about, shared, discussed in literature emerged, including cultural differences between home visiting and child welfare, language differences. The word voluntary means something really different in home visiting and in child welfare, and just other conflicts that needed to be worked through. A new issue emerged in that conversation that none of us had heard before. And that was that once you cleared through those other barriers and got to the place where you were actually trying to do contracts and make payments using FFPSA funds to extend home visiting services to families who might not otherwise get it, there were some real structural differences in the way that contracts and payments work that created a whole new level of barriers. This was new news and something that we were really interested in looking into further. And we were approached by the Doris Duke Foundation and offered some funding to do some work digging into this further. We're so grateful to the Doris Duke Foundation for the resources to do that work. And we ended up doing surveys of all 50 states, as well as focusing in on 5 states in particular with in-depth interviews, states that were kind of in the forefront of rolling out home visiting services to families using FFPSA. My apologies to the tribal friends that I see are on this webinar, although many of the recommendations that we have are also applicable to tribes. And in conversations with tribal programs, I am learning that even when tribal governments are smaller than state governments, many of the same silos and barriers still exist, but we did not have tribal participation explicitly in this work. So my apologies there. So what did we learn as we did this work? First of all, there are some really basic structural differences. Child welfare services are contracted for in a really different way. And that goes back to the history of agencies and actually also arguably to statutory language. So in my words and my understanding, and this is not the way Child Protective Services or child welfare officials talk about this, but child welfare services are paid for with a Medicaid model. So there's a list of services that are provided, and the child welfare agency buys those services from a vendor. And the vendor invoices and receives payment when a particular service, like a supervised visit, is provided to a family. The services that are provided are pretty comparable across vendors and across families. Now, that's a generalization and a little bit of an overstatement, but with few exceptions, the majority of supervised visits, for example, are going to look and be set up in a very similar way. And the payment for the vast majority of supervised visits is pretty standardized. Most importantly, there is no expectation that the contract with child welfare is going to cover 100% of the vendor's costs. And this is just sort of taken as an assumption in child welfare. And it's analogous, for example, when I go to a doctor's office, I expect to pay for my doctor's visit and maybe some lab tests that are offered, but I don't expect that I should cover the cost of operating the doctor's office, paying for their staff. Like I expect to cover just the services that I receive. This is actually a very different model from the way home visiting works. So on the next slide, let's talk about how is home visiting contracted for? Well, in home visiting, in most cases, a state or another payer is paying for a certain number of slots, or maybe paying for one home visitor's caseload, even if the caseload is not 100% full. You're paying for slots that you want to have available to you so that you can put a family in there. And it might take time to recruit families and to complete their enrollment. Secondly, there's a variety of home visiting models. Just on the evidence-based home visiting list that is eligible for federal funding, there are more than 20 models. Some of them are focused on health outcomes. Some of them are focused on education outcomes. Some of them are focused on child welfare outcomes. Some of them start prenatally. Some of them focus on children who are 3 or 4 years old in the years before they enter school. And the services are often customized to meet individual family needs. So not only are the services provided varying across home visiting models, the same model may be providing very different services at a different point in time during the family's enrollment, so that the services are different home visit to home visit and family to family. So the checklist approach that is used by child welfare doesn't really work in home visiting, because if there's a checklist of services that are going to be paid for, I may not, as a home visitor, check off enough of those services in a particular visit to cover the cost of delivering the home visit. So home visiting programs expect the purchase of a caseload or a certain number of slots. And the only way that they can pay their bills, keep their staff on, and keep the lights on is if the purchased slots are paid for, even when they're not filled. In conversations between home visiting agencies and child welfare agencies, this kind of caused people's heads to explode. In meetings between the home visiting state agency and the child welfare agency, the home visiting folks were scratching their heads saying, how can you run a program if you're not covering 100% of the costs? And the child welfare folks were saying, what do you mean we have to cover 100% of the costs? We should only pay for the services we use. So this was a huge disconnect, and it was a disconnect that was built into the contracting systems. So how are the states that are making it work? How are they doing it? Well, the report that we wrote has some recommendations that states have made that they think contributed to the success that they have had. And I should say right up front, even the states that are in the forefront of doing this are still serving very, very modest numbers of families. And they're doing backflips around these structural barriers to try to make this work. So the promise of the Family First Preventive Services Act has not been met. And until we can eliminate some of these barriers, we won't be serving the numbers of children and families that we aspire to and that was envisioned through the legislation. But there are some tips and tricks that can help. So one thing that surprised a lot of folks, once you establish your system, it is not one and done. And you're not going to be able to walk away. There will be hiccups, there will be new information, there will be new things that emerge, and the systems evolve over time. Talking with the staff who can make referrals, educating the staff about what home visiting is extremely important. And they need to be bought into home visiting because they are the folks on the front line talking to families and describing what home visiting is and the benefits of home visiting and encouraging families to enroll. In some states under FFPSA, they've written into their plan that only CPS workers can make referrals for families to participate in home visiting. In other states, the state plans provide for what we call a community pathway so that families don't have to be referred by their CPS worker, but can come to home visiting in other ways. Regardless of who is making the referral, they need to understand what home visiting is and be able to explain it to families. Costs vary, and they vary pretty widely by region, by home visiting model, and by the intensity of family need. If a home visitor has to drive an hour or an hour and a half each way to get to a home visit, that pushes up the per visit cost of delivering the service. If a family needs an interpreter, and we need to have that additional staff and pay for the additional time that it takes to pause and do translation, that also increases costs. So figuring out a payment system that can make adjustments and cover costs that can vary quite widely is extremely important. One of the biggest challenges in all of this is covering startup costs because the language of FFPSA specifies that it will pay for services delivered to families, but it doesn't say anything about eligibility to pay for home visitors, their screening, their recruitment, their hiring, their training prior to having a caseload fill. And so it's often important to braid funding streams with other federal funds. Maybe it's the McVie Home Visiting Program, maybe it's TANF, maybe it's Medicaid. Important to braid funding streams to cover startup costs while the FFPSA funded caseload fills. And of those funding streams, often the most flexible one is the McVie, the Maternal, Infant, and Early Childhood Home Visiting Program. And those are often the funds that cover the startup costs. Just as it's important to engage the line staff who are making referrals for home visiting, it's really important to engage the fiscal stakeholders in different state agencies early on and get their buy-in so that funding processes can be streamlined. And Indiana is one of the states that has done the most work on that. And I know we're excited to hear from Indiana on this call. A few more brief recommendations before I stop. The local implementing agencies are the community-based agencies that are delivering home visiting services. It is also extremely important to engage them from the beginning, particularly in helping to account for costs and calculate reimbursement and establish transparent and trustworthy working relationships. There are going to be hiccups, and you need to be able to fall back on those relationships in order to solve the expected and the unexpected problems. And then the interagency collaboration between child welfare and home visiting, again, bolstering relationships that are going to get you through when the going gets tough is vitally important. And maybe all of this adds up to the final recommendation from states: persist. This is going to take hard work. It's going to take longer than you think. It's going to be more challenging than you think it is at some points in time, but it is possible to break through these barriers and do really important work for children and families. And when that happens, there is a really important payoff, not just for the children and families, but also for state agencies. So one really unexpected outcome of this is that this collaboration between home visiting and child welfare ends up strengthening the system for everyone. And we had a really fascinating comment from the New Hampshire Child Welfare Agency, which had to really change its contracting model in order to work successfully with home visiting. And that was not a simple or a straightforward process. These sort of iterative agreements and the level of supervision of home visiting programs and the back and forth engagement with the agencies that were implementing home visiting was a very new and different thing for the Child Protective Services staff. But it gave them, over time, greater interaction with their providers, more focus on deliverables and outcomes, and they told us really increased the accountability of home visiting programs to the Child Welfare Agency. And what the child welfare officials told us is that over time, they plan to now take the home visiting approach and apply it to many of their child welfare traditional vendor agreements because they like this interaction, they like the focus on outcomes, and they like the improved accountability. So this has been a very rapid, my apologies to Valentina, our stalwart interpreter, a very rapid overview of the recommendations and findings in this report. The report is available online, and on the final screen, you can find it on the ASHV website. There is a lot of technical information and really detailed case studies on the work that's being done by Nebraska, New Hampshire, New York, Michigan, and Indiana, who are not the only 5 states that are in the forefront, but 5 of the states that are moving forward most rapidly to do this. Thank you for all of the work that you are doing to support children and families and to help bring home visiting to children and families who aren't getting it, but who could benefit. Thank you.
Thank you, Kat. Thank you so much. So, all right, folks, we said we were going to bring you the nuts and bolts. So there you go. There's so much more to cross systems collaboration than if you build it, they will come, and just tell somebody it's out there. And it doesn't work like that. We would love it if it did, but it does not. So that was really, really informative. So we are next going to hear from David Reed, who is in Indiana, and he will give you the real life example of what it takes to do this kinds of work and successfully. And so, David, we're going to turn to you now.
Thank you, Dr. Kay. Thank you, Catriona. Your last recommendation of persist.
David, we can't hear you.
You can't hear me? Can you hear me now? Can you hear me now?
Yes.
I don't know. We have new computers here and they are not agreeing with me very well. So apologies for that. Hopefully you can hear me okay as I get through this presentation. But I was saying, Catriona, that was a really great summary, and your final recommendation of persist definitely was applicable to our work here in Indiana. That was a really important component to our getting to where we are today with our home visiting initiative and having it funded through FORI. I'm going to share my screen now. So hopefully you guys will be able to see that. Are you able to see my screen okay? Excellent. Okay. Well, I'm going to talk about our community pathways approach to home visiting that Catriona had referenced a little bit during her presentation, and why and how we developed it. So I think to really understand where Indiana is today, it is important to understand our history. Back in September of 2017, which is the month that I started here at the Department of Child Services, Indiana had 17,204 kids in out-of-home care in child welfare in Indiana. That's a staggering number of kids in foster care across the state. And we have 6.7 million people here in Indiana. And again, over 17,000 kids in foster care. We had another 1,000 kids in residential treatment at that time. And that 17,204 kids represented the fourth most kids in care in the entire country. Indiana is not the fourth largest state by a long shot, but the only states that had more kids in care than us were California, Florida, and Texas. Each of those states has over 3 times our population. We had the fourth most kids in foster care in the entire country. And also at that time, the number of kids in foster care had gone up 83% in the prior 6 years' time. So it really should have been a hair on fire kind of crisis here across the state, seeing that many kids in care here in Indiana. Soon after that time, February 2018, I'm sure you guys all know, that's when FFPSA was signed into law, which obviously was really well timed for a state like Indiana, because it was designed to try to keep kids from entering the foster care system. States could now use federal funding for the first time, our largest federal funding source, to deliver evidence-based interventions to try to keep kids from entering foster care. But the caveat to that was you had to deliver those evidence-based interventions to families in which there was a foster care candidate. What's a foster care candidate? Well, FFPSA has this definition. It's the traditional federal definition of a foster care candidate. And it's a child who is identified in a prevention plan. This is, again, the family first language, as being at imminent risk of entering foster care, but who can remain safely in the child's home or kinship placement as long as services or programs that are necessary to prevent the entry of the child into foster care are provided. So again, you have a child who's at imminent risk of entering foster care without the provision of these evidence-based interventions. But during that time frame, back when Jerry Milner was at ACF, he talked about states could further define who a foster care candidate is state by state. So again, you have your federal definition, but then states could further define who a candidate is in their state. Right around early 2020, if you remember when Family First passed, again, February 2018, they told states that the first evidence-based models would be on the Title IV Prevention Services Clearinghouse in fall 2018. There were no models available on that clearinghouse in fall 2018. In fact, there were no models available until summer 2019. And most of the models that came out at that time were not readily available in Indiana, and probably not your state either. But in early 2020, that's when Healthy Families America appeared on the Title IV clearinghouse as a well-supported model. Now, that was really interesting to me because we, at that time, had Healthy Families America across our state for 25 years. We knew the value of that intervention, and we've tracked outcomes from the beginning of delivering that program across the state. And we know that almost no families that participate in Healthy Families America ever go on to have an open abuse or neglect case with child welfare. So there on the clearinghouse was Healthy Families America. I know a lot about that model. I knew those outcomes, but I also know that none of the families that were studied when Healthy Families America was evaluated were having the service delivered to them under threat of losing their child to foster care. It had always been a voluntary model, as it was here in Indiana. It was a voluntary model designed to help facilitate bonding between new parents and newborns. And we know in our research that if we can get a good, healthy bond between a mom and a baby, we have a safe baby. But again, the model had not been delivered under threat. And so it didn't make sense to me that they were going to put this model on the Title IV Prevention Services Clearinghouse and call it well supported, but then make us do it to an entirely different population that it was never even studied on in the past, which again are these traditional foster care candidate families, families whose kids were at imminent risk of entering foster care. That's not who Healthy Families was ever really evaluated on. Frankly, there's almost no model on that clearinghouse that was evaluated on that population of families. But again, Jerry Milner is saying that states could further define who a foster care candidate is. And so my team, wanted to craft our definition of foster care candidacy to include the families that we had been serving under Healthy Families America for, at that point, over 2 decades. And so that's what we did. We crafted our definition of a foster care candidate to include families that participate in Healthy Families America. And Healthy Families America has their own eligibility criteria for who should participate in that model. So we basically just used that definition of who is eligible for healthy families and applied it to our foster care candidacy definition. These are the exact words that are on our now approved prevention plan. We had lots of spirited debates with the Children's Bureau about how we were defining candidacy. And I kept pointing back to Jerry Milner said we could further define who a candidate is. Since that time, there's actually been a Dear Colleague letter that has been released that verifies that what we have done can be done anywhere. Other states have followed suit. There are some caveats to who can receive 4E funding, who's receiving Healthy Families. Number one, you got to have a child, right? So Healthy Families, you can begin delivering before the child is born. That's an ideal way to deliver Healthy Families. But you can't bill 4E for that because there's no foster care candidate yet. You got to wait until the child is born. So again, you'll be postnatal. The family has to have a family service plan, and the family service plan that is implemented within Healthy Families meets all the requirements of the child-specific prevention plan that's required by the Family First Prevention Services Act. If you read Indiana's prevention plan, you will see that exact sentence that they made us put into our plan that says the Healthy Family Service Plan meets all the elements of the child-specific prevention plan required by FFPSA. The families are not served by DCS. These are families that are outside of our system. They're not monitored by our field staff. The only people within the department who have any idea they even exist is my very small prevention team who have access to the database where the information on these families is stored, but nobody else within this now 4,000 person agency has access to any of the information about the families that are engaged in what we call Healthy Families Indiana, or HFI. And again, every family has to have been screened and eligible based on the FROG assessment. If you know HFA, you know the FROG assessment. So Family Resilience and Opportunities for Growth Scale assessment. So families can self-refer into Healthy Families. We can refer. So let's say somebody called us alleging abuse and neglect. We are not going to substantiate, but the family could benefit from HFA. We can refer the family into the program with a provider, one of our couple dozen across the state that do Healthy Families. We have this in every single county in the state. We serve 11,000 families a year in this program. And again, almost none of them ever go on to have any open DCS involvement because of abuse or neglect. And then other state agencies or stakeholders can also refer families into the program. So here's a little chart there about who all can refer to the program here in Indiana. So that's all I have. Thank you for the opportunity to talk about our work here in Indiana.
That was great, David. I also just love how you totally finished when I gave you the time sign. That was great. So everybody, it's just really good to hear these examples, you know. So here's how we're set up. We've got the nuts and bolts and all the challenges and how difficult it is. And then we've got David in Indiana telling you it can be done and this is how you do it. So it's just very exciting when we're able to hear these success stories. So thank you, David. We do have a question in Q&A for you in particular, so I'm going to bring that up when we get to that portion of the webinar. So right now we're going to move on to Illinois, and we're going to hear from Dr. Kim Mann. I should say that Illinois is my home state, if I haven't said that before. And we're going to hear from Dr. Mann on what she calls the origin story. Dr. Mann?
Good afternoon, and it's a pleasure to be here. It's a pleasure to share, to do a little bit of reminiscing. For a period of time, I was the Deputy Director of the Office of Research and Child Wellbeing, an office created by Dr. Cynthia Tate, and I actually followed her when she departed from her role in that office. And the origin stories of home visiting kind of start with her, and I'm going to pick up from there and tell you a little bit about how we got going. And for us, there was a little bit of, it really was pretty powerful for me to review some of the materials from our origin story. So can I have the next slide, please? I was a part as the Illinois rep for child welfare to the BUILD initiative. And in 2018, there was a particular opportunity offered through BUILD called Project Hope, or Harnessing Opportunity for Positive, Equitable Early Childhood Development. And it was an attempt to help us to strengthen collaboration, to think about system change, and overall how we would deliver services really between entities. And it was, I didn't know what in the world it was going to be when we started. I knew one thing, however, they had a mandate for us. And that mandate was that we would not think about any policy development or programming until we had literally sat at tables and listened to people's stories of their lived experiences. And that was extremely powerful. And that's what I'm going to share with you. Next slide, please. So I actually did two different opportunities. The first was offered by one of our nursing folks here in the Chicagoland area who actually worked with parents after they had lost a child prenatally, and met with them for about a year or more to hear their stories, offer encouragement between the families. And so that first experience for me of lived experience was that opportunity. My second experience, they ask you also to leave your home community. And so I went down to the Peoria region from Chicago and met with really a cadre of folks. It was doulas and home visitors. The home visitors were specifically from parents as teachers. There was some folks that we met with centering pregnancy to talk about prenatal work. And they also had a universal home visiting program from hospitals where they would attempt to identify parents in that particular region at delivery and follow up with a nurse doing a home visit. And so that effort was underway in the Peoria region. And so from that listening, there were a number of things that I wanted to share that ended up culminating into moving an effort forward on home visiting. I'm going to just stop for a second and say that there was some previous work that was happening led by Dr. Tate and others, but also an agency partner that dealt with our teen parents in the child welfare system. And it was a rather small pilot of about 20 or so youth. She can correct me on that number. And looking at the experiences of the utilization and if needed, adaptations for that population around home visiting. So I had that to build on. It wasn't that we were starting from scratch. But here are some of the things that we looked at. Some of the feedback, some of the themes that emerged were issues like access to care. And some of these include actual quotes from families. A mom says, I had to wait for what felt like forever because I had moved from Bloomington to Peoria and all of the consents and records had to be transferred. They kept asking the same questions over and over, which wouldn't have happened if everyone didn't have their lines crossed. So this frustration around access and providers was a big thing. having multiple providers and therefore having to have multiple people that you tell your story to was a really big deal if you're pregnant, vulnerable, overwhelmed by a lot of other things that are going on. And this is something where centering pregnancy was particularly helpful as a way of circumventing that so that people had less frustration. By the way, Illinois at the time also was releasing reports on maternal morbidity that were just absolutely unacceptable across from, placing us really at the bottom in the nation. And so these issues really were not just, abstract. These were critical issues. Access to services for high-risk pregnancies was also noted, and not getting that in a timely way. And so I'm going to jump a bullet ahead and say delays then in starting prenatal care because of delays in Medicaid, insurance were noted. One of the things that was noteworthy is how relationship-based this work is. And there were moms that I can almost hear, reminiscing on this, talking about not wanting to leave their doula who had been with them through such a critical period and during their pregnancy, and then having to transfer it to a home visitor who was, of course, going to be a lovely person, but that wasn't how they were experiencing that necessarily in that transition. There was another story of a delay. There was a Latina mom who was treated as being undocumented. She kept telling us that she was repeatedly asked about paperwork and her immigration status and asking for proof. And she ended up with a delay at 21 weeks until her first appointment could be scheduled. And at that point, she was diagnosed with a very tragic illness, a medical condition. And in this same story, this was extremely compelling when we look at inequities in medicine, because she talked about being told, her husband being told to leave the room, even though she repeatedly told the doctors and nurses that was her husband. And it was when they put him out literally of the room that they told her child had died. And so it's those kind of things that really were very motivating for me, extremely powerful as we were thinking about policy issues and really on the tip of getting our plan developed for Family First. There was a last one that we were already working very hard with, which was Safe Sleep. And, moms would talk about why that was hard for them. Yeah, they knew the rules. Yeah, they'd been given packets and things like that. But they talked about, in particular, this particular mom's quote talks about not always knowing who's in the house when your living conditions are a little unstable, and, wanting the baby close to her to protect it. And so when I left this event, next slide, please, I came back to the office and told my then supervisor that I was going to do my first policy. I'm a clinical person, so doing a policy for me was a big deal. And we wanted to, out of this, get involvement of our moms as early as possible, both to deal with the issues of, healthy births, but also to deal with this amazing support that can be offered, hopefully through doula services, but also through home visiting. We wanted it to kind of mirror our teen parent way of operating in terms of policy, which says if someone discloses pregnancy, we notify someone. And in this case, for Teen Mom, it will be the Teen Parent Network. But in our case, we had this amazing program that you're going to hear a little bit more about in a minute from Pfeffer Horizon, which was our Erickson DCFS early childhood project. And that already based a team of highly qualified early childhood providers around the state in every county, and gave them access, often notification of new cases coming in. And in this case, we wanted to make sure that they would be the ones to know when pregnancy was disclosed, so that they could then work with a mom and go through that engagement process that we don't take for granted in our system. This was a big deal because we found all kinds of issues of lack of knowledge of what home visiting was. We saw all kinds of ongoing, and I'm sure this still remains a challenge across the nation, challenges around the belief of, getting involved with a system will entail, and the threats that they perceive. And so a home visitor, being separate from child welfare, something that our team was able to engage people around, but it does require particularly sensitive handling for that. the some of the limitations we began to encounter right away is that while we were able to deal with our child welfare population, we certainly couldn't fix the healthcare system. And so some of those barriers, we continued to do advocacy around, but we weren't able to deal with those immediately by creating our Family First plan. The things that have been discussed here around financing of that and access to it, we experienced all of that. We experienced those funding challenges by the two largest providers of home visiting services. But we had immediate success with the identification process. We actually had a really nice network of services, and Pfeffer is going to talk to you a little bit more about those barriers because I see the flag has gone up, and so I'm going to transition to her. Thank you.
Thank you, Dr. Mann. I wanted to say when Dr. Mann tells the origin story, it again reemphasizes how important it is to listen to the people that we serve, to listen to the moms and the soon-to-be moms, and to be moved by their stories and by their needs, because it can indeed cause policy to change. And so now we're going to hear from Pfeffer Eisen, who is with the Erickson Institute DCFS Early Childhood Project. And so she's going to talk about how that project is going and has gone with home visiting for the child welfare involved very young children and their families. Pfeffer?
Thank you, Dr. Tate. And thank you all for being here today. As I'm listening to the presenters and looking at who's on this call, I just want to say a sincere thank you to all of you who deal with highly stressed families under highly stressful situations every day. It can feel very difficult it can sometimes feel very hopeless and difficult. And yet what I have seen and what I hope you will also get from this is that in the end, relationships, when they are empathic and look at the whole person and their whole experience, really make a difference. And if I could ask for the next slide, what I'm going to be talking to you about is the way that my project, which has been linking young children who are involved in the child welfare system to early childhood services for about 25 years, we targeted what we call intact families in Illinois. So families maintain custody of their children. They are at risk of losing custody of their children. And this is the population that we are trying to link to home visiting. Dr. Mann worked on a policy that directed families toward home visiting when they were involved in investigations and when they had intact family services open. And that was a lot of work. And we all know that once the hard work of policy is done, there can sometimes be the fantasy or hope that that will turn into access. Any of the case managers, home visitors, or other professionals on this call could certainly tell you that rarely is it simple. So my program is 5 people statewide. They cover 102 counties, all of the counties in Illinois. And they are developmentally trained clinicians. They are navigators of a sort, so they have relationships with early childhood systems, including newly developed relationships with home visiting programs. We started this part of the program in about 2020, so all of you may remember a rather significant contextual factor was happening when we got this going. We started building relationships between child welfare and home visiting for these intact families and child welfare to receive home visiting at a very stressful time. We position ourselves within systems. So we build relationships with child welfare workers. We consult throughout cases, and we follow families from the time the family or the case manager contacts us about referral until the family has either been engaged 6 months or they have decided to opt out of home visiting services. We talked about the voluntary nature of home visiting services and how child welfare is often not experienced as a voluntary system. And so we do a lot of work informing case managers and child welfare professionals of the voluntary nature of home visiting and really try and empower families. If I could have the next slide. So what all of you undoubtedly know is that rarely is there a straight line from referral to engagement in a service. When you involve multiple systems, in Illinois, child welfare is delivered through one state bureaucratic system. Home visiting is delivered through a couple funders, both McVie federal funding and the Illinois State Board of Education funding. The programs are then delivered by a bunch of different providers. So there's lots of different players involved. There's lots of points of view about what is happening. And families are dealing with extremely complex situations. One of the other things that I should say is that we do not have slots specifically for child welfare. Our partners in home visiting are very generous and are allowing us to use the available home visiting slots for some of our child welfare families and prioritizing enrollment for those families. Can I have the next slide, please? So our program believes that you have to approach systemic change at all of these levels, from the policies down to the specific family. And we have there's only 3 levels in the program. I'm the director, there's the clinical supervisors, and then there's the home visiting specialists who are partnering with families, child welfare workers, and home visitors to try and assure engagement and support addressing barriers. I see it as part of my job to get the information learned on the ground back up into the rooms where policies and funding decisions are made. Often decisions are made by people who don't have the experience of what it's like for families or what it's like as a professional. We really see this following and tracking of barriers as an opportunity to tell the story of how systems themselves can sometimes be the biggest barrier. If I could have the next slide, please. So the Erickson Institute is a school of child development, and everything we do here we call relationship-based work. One of the things that our staff really bear in mind is that when you have so many systems and so many points of view, there is going to be a pull for disagreement. There's going to be a pull for frustration. People are going to identify with different members of a team trying to help a family. People are going to have strong feelings, and those strong feelings make it really easy to give up, to blame the other professional, to think, well, if only so-and-so would do this properly, we wouldn't have these problems. And we deal with that by approaching everyone with a lot of empathy, just like family-centered practice says that we believe all parents are doing the best they can. We say we believe all parents and professionals are doing the best they can. We approach everybody with faith that people are trying their very best and that it is conversation and holding of affect. Perhaps we can't do anything, but listening before we try and problem solve and looking to problem solve together is the way through these barriers. Our engagement with everybody is very flexible. If I could have the next slide. So the easiest way to talk about what this work looks like, in my opinion, is to tell a story. So the story of this particular family is we have a teen mom. She's 19 years old. She came to child welfare attention, not for her own parenting, but because her younger siblings were removed. The father was under house arrest, and this teen mom was homeless and had an 18-month-old with a complex medical history. The baby had an oxygen tank, and a cardiologist was following them, and the cardiologist wanted in-home nursing. What mom was able to tell the child welfare worker, who was trying to make sure that her and her baby had what she needed, is that there was a waiting list, and so she couldn't have the nursing that she was supposed to. So this child welfare worker reached out to my staff member. My staff members are positioned in DCFS offices, and we build very strong relationships with workers. We work with the same workers over and over again. The worker wanted home visiting. She wanted mom to have support. So we worked with the case manager. We attended child and family team meetings with the mom, and we talked about what home visiting could offer from mom. We also talked about early intervention being a need given her child's difficulties. And if I could have the next slide, please. So there's a lot of policies, federal and state, that mean this mom is eligible for home visiting and should be automatically enrolled. Of course, what the work looks like often is different, and that was true in this case as well. The first home visiting program that was served her area, we spoke with, and they were quite nervous about dealing with mom because of the baby's medical issues. So we set up a meeting to talk with the worker and the home visiting program about what their concerns were. But before that meeting could even happen, the mom moved out of the catchment area. So that resulted in my team locating a different home visiting program, which had a much larger catchment area. And that home visiting program reached out to us when they had trouble enrolling mom because they couldn't get a hold of her. So then we went back to the child and family team meeting with the child welfare case manager and mom and talked to her about it. And it turned out mom didn't have a phone. Now, the case manager didn't know this because mom was very good about getting in touch with the case manager using relatives' phones. So the case manager immediately said, Mom, you should have told me, and got mom a telephone. So home visiting started to engage mom, but they ran into some trouble there because they thought mom needed therapy for her history of trauma. She had her own history of neglect as a child. My team participated in multiple meetings trying to think about not only what services mom needed and what her needs were, but what is realistic for this woman to do who is homeless and who doesn't have transportation. Our role was to help people think about prioritizing tasks and working hard to bear mom's experience in mind. The other thing that we did was hold a lot of people's anxiety about this medically complex baby. And the next slide, please. As a part of this initiative, we have built a lot of relationships at the funding and administrative level. So we were able to help with a number of the barriers. We were able to figure out that there wasn't actually a wait list for nursing. In fact, they needed information from mom that included a phone number and email she now had. We were able to troubleshoot for early intervention. We were able to pick back up and help support mom when home visiting providers had to change. And we were able to help address mom's concern about the daycare she had not being convenient and going with a neighborhood provider who was much easier for her to access. I have the last slide, please. Now, here is what what you see is families we've identified as eligible for home visiting, families who opted for referral, and those who enrolled. How we look at success matters a lot. Often success of initiatives like this is measured by how many families you refer. We look more at who enrolls and stays engaged. And we've really had a lot of success with this troubleshooting and addressing barriers. Illinois' home visiting enrollment rate is about 35%. And enrollment for the families who we support was 50% in FY23 and is 40% now, although some of those families are still ongoing, and that percentage could go up. So when you help people actually get all the way across the street and engage, you can really make a difference in how many families actually receive help.
Thank you, Pfeffer. It's always, it just sort of makes things so much more clear when we can move from complex concepts to a story about a mom. And now you can see exactly all the different things that a home visitor does, which I don't know about our folks in the audience, but we might not always think that all that range of tasks and activities of support are what home visitors actually do. So thank you for that. Okay, so I'm hoping now that our presenters will all come back on camera. Okay. All right, we're all here. All right. Okay, wonderful. So many things, folks, so many things. There are several themes that I'd like for you all to explore. I think one of the one I want to start with is this issue of the voluntary nature of home visiting and how that actually plays out in a system that is not voluntary. So I'm going to put that out there for the whole panel, for anybody to discuss, as you choose. Whoever wants to go first.
I guess I can jump in first on that. And then I really feel like it's important to deliver evidence-based models to fidelity. We need to do them with the people who they were intended to serve. And most of these home visiting models, maybe like a home builders being an exception, but most of them were developed in a voluntary kind of way. So families choose to participate. And I think that's a really important component for how these models should be delivered. Obviously, there's the child welfare adaptation to healthy families. We have that available here. There was a question that was posed that kind of relates to that and how we deliver that intervention here across the state. But in general, the families who are engaging in Healthy Families America do so voluntarily here. And it's through that foster care candidacy definition that we're able to use Title IV funding to support that work. We also still use TANF. That was mentioned earlier by Catriona. That is another funding source that we use for HFA. That is a great resource for supporting this work. But again, my strong feeling is that any evidence-based model should be done with the people who was intended to serve.
Mm-hmm.
Just to piggyback on David's comments, I think there's the rule and there's the culture, and some of you've heard the term that culture eats strategy for breakfast. There's a belief, and I'm going to start within the community because a couple of years ago there was some data that came forward that talked about 50% of African American families will experience a child protection involvement in their lifetime, which is just unbelievably horrific. But when we talk sometimes about like cross-cultural, cross-system understanding, one of the things that was always struck me about that particular piece of data is that for many home visitors, they are from parallel communities. And so this worry about system involvement is not just on the side of the home visitor, or excuse me, on the family, but also the home visitor. And so it's that kind of cloud around the work that I think is problematic. And we probably need to acknowledge at times maybe there are, less than ideally trained child welfare professionals who maybe push a little harder, but that was not the case in our system with, because we had this intermediary who was relationship based and doing that engagement and outreach, but to get rid of the belief that it might go that way, it was really I'm sure if I first fix this by now, because I've been gone for 2 years, but that's that belief, that cloud, about it's going to be, they're going to be mandated. And we're in a program the whole program is voluntary. Intact Family Services is voluntary.
That is one of the reasons why the entire home visiting field was very nervous about the passage of FFPSA, although they welcomed it. They don't there are lots of families who already prior to FFPSA didn't want to engage with home visiting because the idea of letting someone into the home was very off-putting, and home visitors don't want to be tarred with the CPS brush. But the other thing is the idea that these are parallel systems whose families are not engaged in both families or both systems is really an error. And there's some research to suggest that a third or more of the families who are being served in voluntary home visiting are also involved in the child protective with child protective services. Now, they're not being mandated to be in home visiting, they're choosing to do it, but these systems are in many cases serving the same families.
Thank you. Yeah. I'm sorry to interrupt. I think we have waded into the cloud around this idea of what is voluntary or not. And essentially, it always involves difficult conversations, but it comes down to home visitors can appreciate that child welfare workers have to worry about risk. And child welfare workers often really appreciate when families have a trusted support that they then can rely on the fact that there are other people in there, not just them. A lot falls on child welfare workers and on home visitors. And so what we found is if you bring people together and we can all always agree that we're here for the best interest of children and families, and sometimes we might not agree exactly what is going to make that happen. But it really is about creating those relationships around families.
Mhm. Yeah, let's talk about that. That was kind of another one that I wanted to talk about. Yeah, one of the things that that we learned when we did the TPSN home visiting, that's the teen parent program, and with the home visiting pilot, was that child welfare workers and home visitors don't speak the same language. They don't speak the same language. They can be talking about the same thing. It will not sound the same. And they will. So how do you deal with that? That we have two systems, all, the folks in both systems do have the best interest of the child at heart. We're just going to say that that's true. Then how do we get to where, they're just not speaking these different languages past each other? How do you deal with that? That's for anybody.
So we have been asked this a lot as we've moved through our effort. And what I can say is we have definitely made some trainings. I wrote a training called the Child Welfare System for Early Childhood Providers. What we've learned, though, is that training and knowledge doesn't necessarily help people make sense of what is in front of them, in part because there's a lot of feelings about what's in front of them. So that's why this model and the idea that home visiting specialists can offer long-term follow-up who understand both sides becomes so essential for this to work. It's all a lot more labor intensive than anyone thinks it ought to be or anyone wants it to be. And at the same time, these families are dealing with really wicked problems. And so I think the investment to help systems communicate, very stressed systems, by the way, because like I said, we started this effort right as COVID really hit its stride.
Yeah.
People need more support than we are giving them, I think, the providers. And I think, so the answer is we can train and work on language, and there's lots of efforts in child welfare to facilitate engagement. The other thing that we are looking at doing right now is that home visitors have talked about when you engage a child welfare involved family, how that sort of becomes a preoccupation of theirs. So we're going to pilot a training with home visitors to help families really see the home visiting service as more than just because they accessed it through child welfare, that it's not there only to serve child welfare. Yes, and there's ongoing collaborative groups. Thank you for that. I forgot to mention that. Statewide, where child welfare and home visitors can come together and answer questions and learn together.
Well, that's a great thing. That's new. I'm glad to hear that. Somebody wanted to know how Birth to Five Illinois could connect with the Illinois program. Can they just connect with you over there?
They can email me and I will respond as quickly as I can.
Very good, very good. Okay. We had a question, David, about how did Indiana's numbers in the child welfare system get so high? But I don't want to, ask you to account for such a huge phenomenon. But what I would like you to do is to talk to people about the impact that the expanding the availability of home visiting had on the number of child welfare in case openings.
Sure. Thank you, Dr. Tate. And that's an important question. And we could dive into any part of that. So how numbers got so great here in Indiana, that is a big topic, one that we probably should really spend some time kind of going through. And people would say, well, you've always had healthy families. So then how'd you get so many kids in care? If you had that program available across your state, obviously it must not be working, but they're wrong. And the data would help them see that they're wrong because the families that were coming into care didn't have exposure to home visiting. They didn't have the ability to participate in a service like parents as teachers or other home visiting kind of interventions that we know really clearly in Indiana, like other parts of the country, help keep kids safe and completely out of our system. So that was a big struggle. And when I first got here, one of the very first things I was made to do was cut funding for prevention. When we had 17,200 kids in foster care and our system was really struggling to keep up with that huge increase, we're trying to find resources. And people are looking at, well, let's cut prevention because we got to respond to kids that have already been hurt now, not recognizing that that wasn't going to help. So it was a lot of kind of back and forth, a lot of spirited debates. Have your facts lined up, be able to quote data, be able to quote the research, be able to talk about how foster care doesn't rescue kids. I think there is a mentality that that's what we're doing, is that we're swooping in and rescuing kids from bad people, and they're going to go on to have, sunshine and lollipops kinds of lives. And that's not the way foster kids will describe their childhoods. Almost never. I mean, very occasionally, I worked with a lot of foster kids in my career. Very occasionally, I get one to say, thank God DCS got involved and you took me out of that house. But most of our kids, that's not how they would describe their experience. They love their parents. They want to be with their parents. They just want to be safe there. And that's where things like home visiting can really come in to take families that are struggling, that potentially are at risk of having a kid be hurt. If we can bring in the right supports, we can find a way to keep that child safely with those parents. Not only will that child clearly benefit, not my opinion, plenty of research to back that up, but also so will your state. Because putting kids in foster care is not only harmful to the child, but it's really, really expensive too. And I think that some of the states like mine, that argument resonates, right? Where you talk about what does it cost to put a child into foster care? And then what does their life look like once they've entered that system? Because again, you don't have kids who say, thank you very often for putting me in foster care.
That's right. That's right. That's a great answer. We never have enough time to have these conversations. And I'm looking at this clock ticking away. Briefly, can you guys talk just a little bit about the issue of cultural competence and relationship-based work? Because we have had some discussions in the chat around this issue, around cultural competence. I don't, just take a couple minutes because we want to wrap shortly, but whoever wants to take that on, that would be great.
So with my staff, we've really adopted and gravitated toward the idea of cultural humility. So always remembering that positionality is important and that some positionality might be obvious by looking at people, but a lot of times it's not. Reflective practice includes really slowing things down. And one of the practical things that I talk with my staff about is every time you start to have a reaction and feel compelled to run in and do something, ask 3 more questions to try and figure out what's underneath something. The other thing that I demand of my project staff, which is a hard one, is that privilege be acknowledged and assumed. And that, for example, when you look like me and I'm sitting in front of a family, I represent something that is oppressive. And that's sort of a non-negotiable. Now, that being said, this is a very, very, very hard, intractable issue. So I do not presume to have the answers.
Understood.
I want to speak to it from a different lens, which is, so my current university is a predominantly minority serving institution. And, it is not infrequent that home visitors and the folks that they serve may be of similar backgrounds. But all of Pfeffer's cautions were well taken because sometimes people can think that sometimes that there is automatic competence in the fact that 2 people come from at least this generically even similar communities. not to be not true at all. And so these notions, I've been seeing the thing on band training and reflective practice and all of that, and issues of bias. And really, one of the things that we see happens that creates bias that's separate from attached to cultural competence, I'd say, it's just the complexity, and people want to reduce the complexity, so they blame. And they, they highlight, they pick a thing, and why don't you just stop, And so those kind of things I think are really in particular when people come from similar backgrounds around the issue of cultural competence.
That's a great point. That is a great point. We should not make assumptions that because two people are from similar backgrounds that you have automatic cultural competence going on right there. just another one of those lovely assumptions that we make. I would love to talk for another half hour, but we can't. So I would ask you each right now if you would share your final thought.
Mine's easy and quick. It's always great to see something last after you're gone.
Hey, I know that's right. I have that same feeling.
And I thank Pfeffer and the team for that.
Yes. Who else? Final thought.
I'll jump in. So I think like Catriona talked about, you have to be persistent when it comes to trying to develop the community pathways in your prevention plan. Because there's a variety of experiences across the country with states who've tried to kind of copy what we have done. You can steal from our plan. I encourage you to. It's publicly available, and you can put soldier for feet to the fire and say, wait a minute, how come their plan is proved with the exact language that we're trying? And I would submit that, any evidence-based model, who are they designed to serve? And make those people your foster care candidates, right? Because then you're going to have not only, in my strong opinion, the best outcomes, because you'll be delivering the model to the people it was intended to serve, but also you'll be able to get federal funding to help support that work. Because a lot of times it is the funding that prevents things that we know will be helpful from actually getting off the ground. So I think, again, it was a 1.5-year process from our first submission to finally getting the approval. Submitted in March 2021, got our approval July of 2022. So you got to be persistent, lots of conversations, don't give up.
Don't give up. Thank you, David. Go, Kat.
Relationships matter. So this work is building relationships between children and families. The secret sauce that makes home visiting work is the development of the relationship between the home visitor and the family. But in state and tribal and territorial systems too, it is the relationships that scaffold success and help overcome the problems and challenges. So relationships at every level are the thing that makes this work at the end of the day.
Absolutely. Relationship is everything. Thank you for that. Pfeffer, you get the last say.
Relationships matter for sure. I would say hope is an action and persist. All lessons we learned today. It is an action. It is not only a feeling. Persist, and faith that you're doing the right thing will eventually show itself in your outcomes, but you may not be able to see it in the middle of all the stress.
That was a great last thought from each of you. What a wonderful panel. I appreciate you all so much. Such wisdom here that you shared, and you've left everyone with hopefully not only just great information, but inspiration to persist and to continue to be hopeful. Folks, we are going to wrap up now. Folks want to know, participating folks is what I mean, want to know if you're going to get the slides. Yes. Are you going to get the recording? Yes. Are you going to get other resources? Yes. Will you get the link to Kat's report? Yes. I will also make available to everybody the report on the TPSN and home visiting project from DCFS. And I am sure that Pfeffer will make anything available that you might be asking for as well. I want to ask you again to fill out the survey that's going to pop up right when we end, and also encourage people to join the exchange. It's a great place for conversation. All right, everybody. Thanks, everybody, all the participants for coming. Thanks to my wonderful panelists so much. Thank you very, very much. And we'll close for today.
Thank you.